that affects the... Okay, it says recording in progress. Okay. So it is the alteration of those ions within the extracellular space that will affect the cardiovascular, neuromuscular, and gastrointestinal system. So unlike sodium, changes in the water balance, it does not really affect potassium. Unlike sodium affects, sodium is sodium and water, but potassium changes in the water balance doesn't really affect it. So the normal amount of potassium that we take in a day should be approximately 60 to 100 millimoles. So your potassium will enter into the extracellular space through 3 routes. So usually through the absorption through the small intestines, via the kidney in the glomerular and tubular cells, and also via the membranes of other cells. So insulin has a way of enhancing cellular uptake for glucose and potassium metabolism. So let's go with a case about Mr. Trump. So he's a 72-year-old gentleman with weakness and palpitation. So he presented to the hospital with a history of diverticulosis. He had surgery 2 weeks prior to using this patient, following a perforation resulting in placement of an ileostomy. So he reported that after his discharge, he had a change, he had to change his ileostomy bag more frequently than he had been in the hospital. He's been unable to eat or drink enough because of severe nausea. So he came in, basically dehydrated. So you did routine labs in the ER, and the ER physician called you to see your patient, who is a bounce back to you, Mr. Surgery. And he's saying that the potassium is 2.3. So what are you going to do? Are you going to call, internal medicine for consult, or are you going to fix the potassium yourself? So basically, what are the causes of decreased potassium? So number one, patient has decreased intake. He couldn't really eat. He's nauseous. There's also increased entry into the cells. Example, when there is a chloroquine toxicity, hypothermia, increased availability of insulin can also cause hypokalemia. Then when there's increased gastrointestinal losses, such as vomiting, diarrhea, laxative use, increased urinary losses, you're peeing a lot, maybe you have some kind of diuretic on board. Some patients will continue to take their medications despite the fact that they are, dehydrated and sick. They'll continue to take their diuretics and other medications. Any kind of salt wasting nephropathies, renal tubular acidosis, when patient, has increased sweat losses during the times of heat, dialysis, and plasmapheresis. So basic causes of hypokalemia comes to your head as soon as your patient comes in with a potassium of 2.3. So now we get to the main topic. How do we fix it? That's what we all want to know. So basically, this is the biggest thing you want to know about potassium. Just take a picture of the slide if you can. Potassium has oral and IV formulations. So assuming you give an oral formulation of 40 millimole, is about equivalent to an IV formulation of 10 millimoles. Okay, so hypothetically, once you give 40 PO / 10 millimoles IV, you expect your potassium to go up by 0.5. So our normal potassium, is about 3.5 to 5.2. So if you're giving 40 millimoles to this patient, the patient has a potassium of 2.3 already. So it's going to go up by 0.5. So 40 millimoles is not enough. So basically, the oral formulation, you have K elixir, depends on what you have in your hospital. K elixir is a liquid. I like to use that for older people because it's easier to swallow, although it's, bitter, but you can mix it with orange juice or whatever juice. You also have K lights, which is like an effervescent potassium. K-Dur is a tablet, it's a large tablet. It comes in 20 millimoles and also micro K. Then you have the Jam K, which comes in 8 milliequivalents. You don't want to give a Jam K to a patient with a potassium of 2.3 because we talk about 40 millimoles, increasing it by 0.5. So if you're going to give enough to get the potassium to your normal, they're going to give a lot of tablets for Jam K. So usually the Jam K or Slow K, they don't have Slow K anymore. It's called Jam K. So I recommend that you use that in the office only, okay? Or most of those your patients who are on diuretics or hydrochlorothiazide, their potassium is grumbling between 3.3 to 3.5. Those kind of people are the ones you want to use Jam K for because you are not at risk for getting them significantly hyperkalemic, okay? So don't use it in the hospital if you're going to try to replace patient's potassium if it's that low. So for the IV formulations, 10 milli equivalent mini bag is usually the basic ones. You can use that on the ward. You cannot use the 20 milli equivalents on the ward. It has to be used through a central line. So the patient can be in the ICU or on the ward, but they have to have a central line for you to prescribe 20 milli equivalents IV. So if you want up to 20 or up to 30 milliequivalents, you can go ahead and say, I want 10 milliequivalents IV times 3 bags. So each bag goes over 1 hour. So 10 to 1 hour. So that's easy for you to remember. If they have a concomitant phosphate deficiency, you can go ahead and give potassium phosphate, okay, which comes in 15 millimoles and 30 millimoles. 15 millimoles can be given over 2 hours. 30 millimoles can be given over 4 hours. Do we have any questions on it? Because it's an important slide. Any questions? I'm assuming there's no question and I should proceed. Okay. Is there a question? Did somebody say something? Okay. I didn't hear you. I'm not sure if... Okay. Yes, I can hear you. Your mic is off, Dr. Duru.
Thank you, Ma, for this wonderful lecture. If I understand clearly what you mentioned, if you have to give a patient any amount of potassium greater than 10, that's from 20 and above, it has to be in the ICU and it has to be via central line.
No, if there's a 10 milliequivalent bag and there's a 20 milliequivalence bag. Okay, the 20 milliequivalent bag is more concentrated than the 10. So if you want to give the 20, it has to be through a central line. The patient may not be in ICU. So if you're going to order potassium and you want IV, you have to use 10. So you will say, I want 10 KCl, 10 milliequivalents IV times 3 bags. So if you want 20 milliequivalents, so don't order it as KCl 20 milliequivalents. Because, the new nurses, some of them may not know, they can give the 20 milliequivalents through a peripheral line and burn the patient's blood vessels. The patient can die if you do it through a peripheral line. So you want to say 10 milliequivalents IV times 2 if you wanted 20 milliequivalents on the ward, okay? All right.
Dr. Akinfiresoye, please.
Yeah.
Thank you for shedding light on this. However, there's 40 millimole preparation in 1 liter for KCl.
Yes. So I wouldn't give that because you're just giving the patient volume. Okay. So you're giving the patient volume and you're not going to go up more than 0.5, as I said. So for 40 milliequivalents. So there is 40 milliequivalents in 1 liter. So that one is good when you're doing like somebody has like diabetic ketoacidosis and you know the potassium is low, you're trying to give them volume also. So but
Okay.
the patient does not need volume and the patient just needs to replace your potassium. Just give 40 milliequivalents oral, or you can give your, if you don't, where you're working, if you don't have the IV formulation, you can give the oral 40 Q4 hours times, because the maximum they can get is 200 a day. So usually I'll go 40 Q4 hours times 4 doses, if they can follow.
So this 10 milliequivalent, that's the 10 millimole in 100 mils, I believe.
Yes, it is.
Thank you.
Okay. All right.
So there's a question on the chat box, Dr. Jami.
Yeah, sorry, I can't see the chat box, so somebody will have to.
Thank you. That's from Dr. Jami. He said, thank you. How long will they take the oral for before we have 0.5 increase? Like
So-
if you give oral, for how long are we going to wait before we get the 0.5 increase?
At least an hour.
Okay. Okay.
At an hour. Yes.
I have a question, Ma.
Okay.
For the IV, because for the oral, we can do every 4 hours. IV, are we able to do that as well?
You can do
Or
IV
just once a
components.
day?
No, you can do IV every hour.
Okay, thank
So
you.
if you're going to give 3 bags, that means 3 hours concomitantly.
Is there a max per day?
200.
200 too. Okay,
Yes.
thank you.
Dr. Akinfiresoye, if I may ask again, for the 10 milliequivalent, you
Mhm.
can give 4 of that. I just need to be sure. You can give
can
4
give-
of that.
Yeah, you can give 4 of that. So it's going to go over 4 hours.
Okay, and you can do that how many times? You said maximum of 200 in a day, right?
Yes. But I don't see any patient needing up to 200 in a day. So yeah, so you can give, once you give 4 over, the maximum I do is 4 over 4 hours. That's the maximum. Then I will check it.
Mm-hmm.
Then wherever the potassium is, you know, if with the 0.5 rule, you can now give a little bit more.
Okay, thank you.
Yes. So so don't just go and give like up to that amount. Just do, and for oral too, just go, I will go 40 every 4 hours times 4 doses. Then I will check the potassium if it's really low. But you know, if you put someone's potassium is say 2.5, if you give 40 millimoles, you are expecting by the time you check it to be around 3. Okay, so if you give 80, you're expecting it to be about 3.5. So try it with, you know, a few of your patients, see what the potassium is, give them only 40, check the blood work, see what the results are. So that's at least, so then you can know to next time what you want to give. All right. Okay, so I'll continue. So we go to Mr. Doolittle. He's a 62-year-old male referred from the hospital. He came from home hospital after some complaints of feeling unwell. So he mentioned that he had been feeling fatigued, having some chest discomfort. He was found on the floor in his washroom the day of the referral. So nobody really knew how long he was on the floor. So he has a background history of type 2 diabetes, hypertension, benign prostatic hypertrophy. He was on metformin, Ramipril, and tamsulosin. So while he was in home hospital, I don't think they had labs available. So they did an ECG for him and noted that he had an abnormal ECG. And therefore they referred him, without doing the blood work, sent him over to the main hospital where we work. And he had shown that he had tall T waves. Okay, so because he had chest discomfort, he had tall T waves. So we, you know, cardiac workup was done with blood work and everything, and yes, he still had tall T waves. His creatinine was 340, and he had a potassium of 9. So hyperkalemia. So let's talk about hyperkalemia. What do you do in the meantime to be able to help the patient with unstable cardiac membrane? So basically hyperkalemia, few causes of hyperkalemia. renal dysfunction, patient has some kind of cell death, because when you find somebody on the floor, you don't know how long they're on the floor. They could have rhabdomyolysis. So when you check their creatinine, you also want to know what their CK levels are, because significant muscle breakdown can lead to the hyperkalemia. So the patient can also have tumor lysis syndrome, burns, acidemia, hypoaldosteronism, and medications. So when you're looking, when a patient has hyperkalemia, the first thing you should look at is their list of medications. Are they on potassium-sparing diuretics like spironolactone? Are they on ACE inhibitors? Those are the things you should hold. ARB also can cause it. NSAIDs, antibiotics like Septra. Succinylcholine is not very common that we use that, but again, they will use that. The anesthesia will use that if you want to intubate a patient. So before anesthesia intubates, you should ask what is the patient's potassium before you use succinylcholine. And if a patient takes in potassium excessively, let's say they are on potassium pills and they just keep taking it. So those are the things you want to stop first before you go ahead to try to correct the potassium. And if they're renal dysfunction, if they're rhabdomyolysis, you want to also give them some volume also at this time. So what are the options of treating hyperkalemia? So the main goals of management here is to, number one, stabilize the myocardial membrane by antagonizing of membrane action of the potassium. Number two, you want to redistribute the potassium by driving the extracellular potassium into the cells. Remember, I told you that you have 2% in the extracellular space. So that's what you're measuring. And you also want to eliminate the potassium from the body. So there are 3 stages. So the first stage, because the patient has these ECG changes, you want to start with stabilizing the myocardial membrane. What do you give them? You want to give them calcium chloride, 2 grams IV times 1 dose. Or if you don't have calcium chloride, you can give them calcium gluconate, 2 grams IV times 1 dose. Okay, so I usually like to write it and say, as an order, I'll write number 1, give calcium gluconate or chloride. Number 2, they will be able to give, you'll say according to this sequence, that's what you want them to give. Okay, so number 2, you want them to give 50% dextrose. And the reason why I like to give dextrose before insulin, God forbid the patient is giving insulin and there is a code blue. Your patient is already giving insulin, your patient is not diabetic, and all of a sudden, the nurses give the insulin and the patient is dead without dextrose. So I always say give in this sequence. So calcium, number 1. Number 2, give dextrose. Okay, 50% IV times 1. Number 3, give insulin. So it's regular insulin, 10 units IV. It's not subcute. IV times 1. So we've done number 1, number 2, number 3. So plus or minus, you can give sodium bicarbonate. So, but because of risk of sodium overload, I hardly give sodium bicarbonate. I just go ahead and proceed and give a beta-2 agonist, which is albuterol, mostly Ventolin, NEBS, 5 to 10 milligrams Q4 hours times 3 doses. So I do this times 3 doses because it takes 4 hours for, the potassium to start seeping out of the cell again. So you check the blood work every 4 hours. It's difficult to check less than 4 hours anyway. So while you're checking your blood work every 4 hours, there should still be something checking the potassium, okay? Because you can always reshift. This is a shifting method. You can reshift every 4 hours, but you don't want to, I always tell my residents, you still need some soldiers guarding that area. You don't want to pull all your soldiers at the same time. So that's why you need to continue to give your NEBS every 4 hours while you're waiting for the blood work for the rest. So say you have done this initial shift now, and your potassium has dropped to, say, 7.0, because once you do a shift, you expect your potassium to drop like, say, 1.5 to 2 millimoles. Okay, you do the shift, your potassium has dropped from 9 to 7. We want to repeat an ECG. This is 4 hours after. We want to repeat an ECG if our T waves are still tall. You're going to start from the scratch, give the calcium again, give the glucose again, give the insulin again. Then your beta-2 agonist is still on board at that time. Okay? So now the period, then the final one, you want to eliminate it from the body. So you can, if the, either way, depending on what your patient's clinical condition is. If your patient came in fluid overload, this is your opportunity to eliminate using loop diuretics. If your patient came in dry, then you don't want to use loop like diuretics. You want to use some kind of potassium binders. They do have, like, the pitoromias, the sodium zirconium. They have them, but they don't really use them because they're expensive. So most of the time you have to use K-Exalate instead. So the K-Exalate will bind the potassium, and eventually it comes out as stool. So when you want to give the patient, you want to tell them that they likely will have diarrhea from the K-Exalate. If you do this, say you do that shifting the first time, your potassium did not budge. Say it's just still 9. It didn't budge. You have to start contacting nephrology at that time for dialysis. Any questions? Is there any questions? Okay. So that's hyperkalemia. So we'll go ahead and look at another case.
Sorry, please.
Okay.
Sorry, I have a question.
All right.
Are there indications, like in the last case where the patient was already having ECG changes and was kind of like symptomatic? Are there indications where we need to take the patient for dialysis? Like maybe you give the calcium carbonate for the stabilization and the insulin to drive it in, and then have to take the patient in for dialysis because you want an immediate effect rather than going for the other medications that bring the potassium out. Are there indications like that?
Yes, there's indication like persistent hyperkalemia. So as I said, if you try that initial shift, it doesn't work, then you need to start calling nephrology for dialysis. It's not that when the patient gets, because most of these things we're talking about, you're talking about from your home hospital where you have to first of all arrange for stars, arrange for transport, all these things take time. You have to be doing stuff. And once you do the initial shift and it does not budge, then you need to, contact nephrology for likely dialysis. Okay.
Thank you.
Usually it will go down, but on rare occasions where it does not budge, then that's when you call nephrology. But that being said, you still need to continue the shifting while the patient is trying to be transported. Not that we will not do anything, even if you are trying to transport the patient.
Okay, thank you so much.
You're welcome. Is there any other questions? All right, so basically for hyperkalemia, remember now that we have to stabilize the cardiac membrane first. Number 2, then we shift with dextrose and insulin. Give your dextrose first. Then your insulin, which is regular insulin, 10 units IV, not subcute. Then you eliminate. You eliminate through the urine or through the GI tract. So only use Lasix if your patient is already fluid overload, not if your patient is dry like a bone and you're giving Lasix. No. Only use it if your patient came in fluid overload, and if they're not fluid overload, go through the GI tract. Okay. So, Mrs. was admitted to the hospital with a stroke. So other background history include hypertension, hypercholesterolemia. She's a lifelong smoker with severe COPD and atrial fibrillation. So the initial admission shows sodium levels had been like 126 when she came in. And, you had the patient admitted, and later on the resident tells you that the sodium has gradually started trending down, and all of a sudden you find out your patient's sodium is 110. So she's waiting a transfer. She was better. She was waiting a transfer to respite care, but you can't send this patient to respite care with a sodium of 110. So how do we go about treating a patient with hyponatremia? So let's go through this. So you have to get your pen because we're going to do some calculations. So get your pen ready. I don't have my calculator here, so I'm going to be asking you to calculate a few things. Okay, so sodium. So sodium functions as a primary determinant of blood osmolality in the body, and is involved in regulation of the extracellular volume. Sodium disorder is generally due to changes in body water. It's like you have a cup of water, you're pouring salt in it. Depending on the amount of water in your cup, that depends on how salty the cup of water is. So it depends on, if you take half a cup of water with 1 teaspoon of salt and a full cup of water with a teaspoon of salt, you know that it's more salty with half a cup of water. So abnormalities in circulating sodium will affect the neuronal and the neuromuscular functions. And most common is hypoosmolar hyponatremia. So in order for you to be able to treat a patient with hyponatremia, you have to examine your patients. So you need to do a volume status exam. Is the patient dry, or is the patient euvolumic, or is the patient hypervolumic? So that will tend you towards the treatment of this patient. You cannot just take a phone call and say, oh, the sodium is this, let's do this. No, you need to know what is the clinical situation of your patient before you can try to treat the patient. So other things to check is the urine osmolality, urine sodium, fractional excretion of sodium, and the serum osmolality for you to at least be able to make a diagnosis. In my hospital, we cannot, all these things like the urine osmolality, serum osmolality, all those things go out. So the patients, you have to clinically treat before, because it usually will, the results will come back after the patient is already well. So, but again, academically, you can do it if you really want to know what these results are. So for hypovolemic hyponatremia, I always say it's too little water when you don't have enough water. Patients' urine osmoles usually is greater than 300. The urine sodium is less than 20, and the fractional excretion of sodium is less than 1%. The calculation for fractional excretion of sodium is there below at the base. So patients can have hypovolemic hyponatremia due to extrarenal losses, say they are vomiting, diarrhea, or have some kind of third spacing. They can also be on diuretics. It could be aldosterone deficiency, renal tubular dysfunction. So just basically losses, GI losses too. So we'll go back to how we are going to treat each category. So this is hypovolemic hyponatremia. So this next slide tells you guys about how much sodium is in a bag of IV, depending on that kind of IV you want to use. So we have 5% sodium chloride. It's rarely used. I don't even know whether we have that. But in the IV of 5% sodium chloride, you have of 1 liter, you have 856 milliequivalents of sodium in it. And once you give 1 liter of that, you bring the sodium up by 17. But again, scratch that. It's just for your knowledge. I don't think you ever have to use 5%. However, about 3%, we do use 3%. In a liter of 3%, you have 513 millimoles of sodium. So I'm just going to explain more so it doesn't become confusing. I'll tell you this and I'll explain what I'm talking about. In normal saline, 1 liter bag of normal saline, you have 154 milliequivalents of sodium infusate. In Ringer's lactate, you have 130 milliequivalents of sodium infusate. So hypothetically, if you are going to give a patient 3% sodium, their sodium levels will increase by 9.4. Okay, that hypothetically. So now, where are you going to start? You already know that you cannot increase your sodium by more than 0.5 millimoles per hour or 12 millimoles per day. Okay, and you must not go higher than that because excessive correction can cause what they call cerebral pontine myelolysis, which is you are locking in the patient, locked-in syndrome. Okay, so you don't want to do that. So usually I always tell my residents, don't target 12, target 10 or even 8 because, it's just like you driving in the snow. When you're driving in the snow, the way you hold your brake compared to when you are not, in the snow is different. You have to stop before you get to the oncoming vehicle, of course, because your car is still going to continue to slide down. It's the same way at the sodium. Even if you stop at 8, it's still going to slide up to 10. So you have to have that in mind when you're doing a correction. You cannot correct more than 12 millimoles per day, but let your correction stop at least 8 to 10 millimoles so that, because that it's still going to slowly slide up to that 12 millimoles. Okay. So now let's calculate. So our patient's sodium was 110. So infusate sodium, let's assume we are, okay. Can anyone tell me what kind of sodium you are going to use to correct the sodium of 110 now? Hello, people.
Maybe the 3 gram.
Okay, so 3. Okay, good. So the 3 has 513 infusate. So when the first line says change in sodium per liter infusate. So we're talking about what will be your change in sodium with 1 liter of the kind of fluid that you want to give. Okay, so Bukola is saying that we're going to give 3%. So 3% has 513 of sodium. So we'll put it on that infusate sodium, that line, 513 minus our serum sodium is 510. Sorry, it's 110. All over total body water plus 1. So total body water in this lady is 0.5, times the weight of the patient. The patient is 70 kilograms. So 0.5 times the weight is 35 plus 1. Okay, let's have somebody calculate that. So 513 minus 110 all over 35 plus 1, that's all over 36. Take your phones, calculate.
Uh, 11.19.
Okay, so approximately 11. All right, good. Let's go to the next line now. What is the free water deficit? Okay, so 140 minus 110 all over 140 times the total body water, which is 35. So 140 minus 110 all over 140 times 35. So let's get that number too. So 140 is the standard of the sodium where you want to get the patient to.
9.5.
1.5?
9.5.
9.5. Okay, good. Okay, so let's also try, so let's put that aside, okay? Let's also try 0.9 saline. 0.9 has 0.9 saline has 154 milliequivalents, okay? So it will be change in sodium. Sorry, the infused sodium will be 154 minus your 110 for the patient's sodium all over 36. Let's calculate that too for the 0.9% sodium. So 154 minus 110 all over 36. Come on, people, use your calculation brain.
1.2.
That's 1.2.
1.2, excellent. Okay, so approximately 1. Okay, so now, so this patient's sodium is 110. So if we were going to give the patient 3% sodium, the patient's sodium is going to go up by 11. Okay, what is the free water deficit for this patient? This patient is deficient of 9.5 liters. You are not going to pour in this 9.5 liters for the patient at once. Okay, you want to give it gently. So if you are going to, because we already talked about, we cannot increase the sodium by more than 12. Okay, so you are not going to give this patient 1 liter of the 3%. But assuming this patient still needs volume, okay, you can also give the patient the 0.9%. Okay, you know, because we talked about the 0.9% normal saline, getting the sodium up by 1.2, approximately 1. So we're saying that if you give 1 liter of normal saline, the sodium will only go up by 1. So what do we want to do for this patient? Anybody have an idea? Let's juggle our brains. So the patient can get 9.5 liters a day, but you're not going to give 9.5 liters. And the normal saline, 1 bag, 1 liter will only bring up your sodium by 1 millimoles. So if you give a patient 1 liter of normal saline, the sodium will only go up by 1. So there will be 111 if you give 1 liter. So if you give 2 liters of normal saline, their sodium will go up by 2. That will be 112. However, if you did give that 3%, 1 liter, their sodium will go up by 11. So you can give half of that half of the 3%. Okay, if you give half of the 3%, the sodium will go up by 5.5. In addition, you can also give another 2 liters of normal saline, which will increase the sodium by another 2. Okay, so that means that patient has received 2.5 liters on that day. Am I confusing people, or are you guys getting what I'm saying?
Yeah, a little bit of both.
Yes, we got you.
Both.
So basically, you are giving them a little bit of both. You are giving them 3% saline. You're giving them only 500 mils. Because if you give the whole liter, your sodium will go up by 11. Yeah, and you don't want it to get to 12, actually. So you can give 500 of that 3% within that 24 hours. And within 24 hours, you can give an additional normal saline, the 0.9%, 2 liters, because assuming, you know, this patient is dry, that's hypovolemic, they're dry, so they still need volume and they need that sodium too. But 110 is so low that they can, you know, have some seizures, they can become confused. So you want to correct it, but you don't want to go more than 12 per day. So for you to be able to achieve that goal, you can give 500 mils of 3%. Usually I'll give it at 50 mils per hour for 10 hours and stop. So that's 500 mils. 50 mils per hour for 10 hours, then discontinue. Then the normal saline, you can give it, say, 100 mils per hour, or whatever, however way you want to give the normal saline, as long as you give 2 liters in that day. So this way, your sodium at the end of the day would have increased 5.5 from the 3% and 1 for the 2 liters that you have given. So 6.5, 7.5. So you've been able to achieve an increase of 7.5 of your sodium within 24 hours. So the next day, you can now recalculate. So at this time, your sodium is 17.5. So you now go to this formula and recalculate again. At that time, your fluid deficit will be less. But the infusate sodium and the calculation is still the same, but your fluid deficit will be less at that time. Any questions? So it's an estimate of how to correct your sodium and how not to overshoot.
So thank you.
Yes.
Okay. Okay.
You're off again. Your mic is off.
Okay, if you want to correct the next day,
Okay.
I just want to confirm that means you have to repeat the sodium levels like in the morning on that day and then calculate, not what maybe you got after the correction the day before.
No, you have to calculate based on what the current sodium is.
Okay. All right.
Yeah.
Thank you.
So thank you, Dr. Akinfiresoye. So for patients that are euvolemic, so you can just go ahead and do the maybe like the 3%, like maybe 3/4 of the bag to achieve our aim instead of giving volume.
Yes. So they don't need volume, they're euvolemic, so you don't have to give them volume. So those, you can just do the 3%. Then again, for euvolumia, we'll talk about it. We'll talk about euvolumia next. It's just based on what the cause of the euvolemic hyponatremia is. So we'll talk about it next. So, but thank you for that point. Is there any other questions? Because this can be a little bit confusing, but once you have this formula and everything, you have an idea of how to estimate what your sodium levels are so that you don't have to.
And when we use,
You said that you could give 500 mils of the 3%. Have you ever seen any doctors give a weirder breakdowns, like give 750 or 250?
It depends on how much, because 1 liter will put your sodium up by 11. Okay, so we're going by how much will your sodium go up if you give 1 liter. So if you are going to give 750, I'm not really sure how to go about that, because if you give a liter, it's going to go up by 11. Okay, so half of it will go up by 5.5. You understand? So this is what I'm going by. So if you give 750, I guess you go up by, say 8.5 exactly. But again, as we said, you don't want to go too fast. You don't want to go more than 8 to 10 on, per day, because even when you try to target that, your sodium still continues to move. So this is just an approximate. You don't want to get to 12 within a day. So to be safe, I always don't go more than 500 per day at 50 mils per hour for 10 hours. Any other questions?
Dr. Akinfiresoye, thank you for the presentation.
Okay.
When it comes to using oral, how do you estimate? I know that one is usually for mild cases of hyponatremia.
Yeah, so I don't, while the patient is in the hospital, I don't correct sodium with oral. Okay, the only people I will give oral sodium to are people who say their sodium are 130 to 135. They are euvolemic. They have some kind of salt wasting problems. And they are home, so you can give them like a sodium salt, but I hardly use it. I see patients on it by their family doctors, but I hardly even start a patient on it. I'm not saying it's bad for you to use. You can use it, you know. You have to watch for fluid retention and stuff like that. But I hardly use it because I'm always in a situation where I'm correcting acute sodium, not like a chronic sodium, if you know what I mean.
I do. Thank you.
Okay.
Hey, good morning, Sandy. Yeah, Dr. Abdoye.
Yes, Dr. Abdul, nice to see you, my humble classmate from Great Ife. Go ahead.
Yeah, about the sodium tablet, actually, you're absolutely right. The only indication why people use it is just in cancer patients when they have euvolemic SIDH. And because of that cancer being still active. And so they've got inappropriate ADH on. So no matter what you do, you just see their sodium is just around 124, 125, and not the rest. So you can just use that to just try and bring them up a little bit to about 128, 130, but that's the only indication. You should not really be using sodium tab in an acute situation. It's only for chronic and it's mostly in cancer patients. Otherwise, it's not really advisable for anyone to use it.
Thank you, Dr. Abdul. Dr. Abdul is our nephrologist in the house and is one of our speakers in this forthcoming conference. Please be there. Thank you.
And it's also my classmate in Great Ife. What a small world. All right, so is there any more questions that we can proceed?
If I remember correctly, when you were teaching this to me, I think you said if it's less than 130, if it's less than 130, you can now start thinking about correcting, or less than 125.
You can, I'm sorry, I didn't hear you.
For sodium, for correction, we're not really correcting it. It's like maybe 131, 132. We just kind of see how it's going. But then if it's getting below 130, we can now start thinking about correcting, right?
Yes, yes.
Okay, thank you.
Yeah. Okay, so let's continue. So euvolemic hyponatremia, once they have enough water. So in this case, you know, your urine osmosis will be less than 100, urine sodium greater than 30. So you can have euvolemic hyponatremia in patients who have SIADH, syndrome of inappropriate ADH. And people with SIADH are mostly people who have cancer of the lungs. They can have a stroke or some kind of cancer in the brain. They can have inappropriate SIADH. So hypothyroidism, adrenal insufficiency, psychogenic polydipsia is, I always talk about this case where I have this patient he's a psychiatric patient. He was drinking 40 glasses of water a day. And he was drinking that because he was also drinking 40 cans of beer a day. So as soon as he drinks this kind of beer, he'll use the water to wash it down because he feels that he doesn't want it to be in his throat. So this patient's sodium was always like between 115 to 116. So this patient had what they call beer potomania and also psychogenic polydipsia. There was no way for us to treat it until we got him into the nursing home. To stop all that, then everything suddenly corrected. So patients with who are old, they call them tea and toasters. They don't really have enough nutrition, so their sodium is low nutritionally. So how do we treat? So based on the underlying cause, you fluid restrict them. I don't really go more than less than 2 liters, fluid restrict for 2 liters, then treat the underlying cause. As a colleague of mine said there, if the sodium is significantly low enough that it can give them symptoms of seizures or, confusion, you can proceed also to give these patients sodium, like the 3% we talked about, but they don't need volume, okay, because they are euvolemic already. You need to examine your patient, see what, levels they are. Are they euvolemic, are they hypovolemic or hypervolemic, for you to know this. So that's why you have to examine your patient, okay? So treat the underlying cause. If it's low enough, I don't really give the 3% unless it is less than, say, 120. Okay, if it's above 120, I just fluid restrict and see what the patient does. If If it's less than 120, they're already coming to that stage where they will start having all those symptoms. So I will go ahead and give the 3%, because in such a patient, they don't need volume. And if they have SIADH, they are roaming between that 120 and above. If it's because of cancer, then you can go ahead and do that oral sodium as they go home. Is there any questions on this one? This one's quite straightforward. So you only need to do the big calculation if they're hypovolemic anyway. So if they're euvolemic, you just want to look for the underlying cause. So if they're hypervolemic, so that means they come in swollen all over. Why? Is it because they have heart failure? Do they have nephrotic syndrome, anything with their kidneys? Do they have liver cirrhosis? In such a case, if their sodium is really that low, say 110, you don't want to give volume also. You only want to give them sodium, okay? Then you want to diurese them. Sometimes even just diuresis without even the sodium will just, correct things. You know how I talk about water and sodium mixture. So when my patients are coming with liver cirrhosis, they have significant ascites. I had one that came in with a sodium of 112. All I needed to do was to do a parasynthesis on him. I took out 7.5 liters. I checked the sodium again. His sodium came up to about 120. I didn't have to do anything. So all has to do with, balancing the water and the sodium. So our next case, 82 years old male, lifelong smoker with end-stage COPD. His wife had decided on comfort management, but his estranged son, who happened to be a paralegal, shows up. You know how those people come. They've never seen their father for years, and suddenly they want to fix everything, and convinces his mother to change the goals of care because of his guilt of absence. So patient's GCS was already 9 over 15, and his electrolytes were completely out of range. So his sodium was 165, potassium was 2.0, so phosphate 0.35, magnesium 0.45. So this kind of electrolyte abnormalities is the kind that I like. They have to look through everything and try to correct everything. So after multiple family meetings, it was decided that patient should be transferred to ICU because they wanted to resuscitate the patient. The patient was no more like a DNR. So you want to correct this patient's sodium first because this patient is like unconscious. So, correct the sodium. So hyponatremia can be due to water losses, diarrhea, vomiting, excessive sweating, diabetic insipidus, reduced water intake, like in the case of this patient. A lot of patients in the nursing home who cannot reach for water because you have that thirst, you can reach for water, but if you can't, your sodium will be high. Before you know it, the patient will be confused. Before you know it, the patient will be unconscious. So that's what usually happens to patients who are paralyzed in the nursing homes, and they just end up dying because they can't reach for water. Their sodium likely very high. Then excessive sodium intake, so you give them sodium tabs, they can become hypernatremic, hypertonic saline, and sodium bicarbonate. Oh, Abraham, sorry, do you have your hand up?
Yes, I do.
Yes.
I just wanted to, about regarding, I mean, I'm ENT, so I don't often get involved with electrolyte imbalance these days. But I remember many years ago when I forayed into general medicine, there was this, I wonder what your thoughts are about central pointine melanosis in hyponatremia and, in terms of correcting hyponatremia in that condition. I remember I saw one many years ago in England. What are your thoughts about that?
Well, basically, you want to prevention is better than cure. That's what I would say about central pontine melanosis. If you overcorrect, that's why I talk about the 0.5 per hour and the 12 millimoles per day. So you don't want to overcorrect more than 12 millimoles per day, or they can develop the central pontine melanosis. And if you have inadvertently overcorrected, you can give them DDAVP. to stop the correction. So sometimes they can, most of the time, they will improve with the DAVP. Sometimes they will not correct and they will, you know, become locked in. So it's like, I think it's more or less permanent. So really, there's nothing you can do once they have central point-time malinolysis. So that's why prevention is better than cure. Don't overcorrect.
Thank you.
Is a medication that you give to try to reduce the correction rate.
Thank you.
Okay. And you can just, you know, give it through the nose, and you can give it, there are different routes in which you can give it. All right, so hypernatremia causes, we talked about the water loss, reduced water intake, excessive sodium. So treatment of hypernatremia, the biggest thing you want to know, what is the water deficit for the patient? Again, you don't want to overcorrect sodium. You don't want to drop it too fast because their brains can swell and they can cone. So because of that, you don't want to correct the sodium again. You don't want to drop it too fast. So the same law, 0.5 per hour, 12 per day. You don't want to drop it too fast. So what is the water deficit for this patient? And I always say, okay, what is the change per liter infusate also? So patients with hypernatremia, you basically want to give them a fluid with little or no sodium in it. Okay, so you don't want to go and start giving them normal saline. They are very dry, yes, but you don't want to use normal saline because it has that 154 millimoles of sodium in it. So basically for this kind of patients, you want to go with just water that is D5 water, or you can also use half normal saline, which is half of the 0.9%. I hardly use Ringer's lactate, so I either go with half normal saline or D5 water. Sorry, Fisayo, I didn't hear you. Fisayo, did you say something?
You can go on, please, Dr.
Okay.
Alex.
All right. So basically, you need also to calculate this for you to be able to know what is the what they call it, free water deficit for a patient with a sodium of 165. So you can go ahead and, you know, slot in the sodium of the patient, which is 165 minus 140 over 140 times the total body water of an assumed 70 kilogram patient. So based on that fluid deficit, you hold on to that. And so you now will also want to know what is the change per liter infusate of whatever kind of fluid you want to use. So say you are using glucose D5 water, the infusate for D5 is 0. There's no sodium in D5 water. So basically, when a patient has hypernatremia, it's recommended to use more of D5 water, or if they are diabetic and, you know, their blood sugars are ranging high, you can use the half normal saline to fluid resuscitate them. Okay. Any questions? Yes, Dr. Harrison.
Well, with regards to this patient who is 82 kg and with his comorbidities, I'm assuming we'll have to use the lower one, the 0.45 for his total body water.
Yes, no, we're assuming the patient is 70 kg and the patient is 82 years. So you can use that one. You can use 0.5 or you can use D5 water. Okay. Because if we can do the calculation here, but I don't know if we are all up for another calculation, but basically this is the formula. And if you slot in those numbers, you will be able to have what is your total water deficit for these patients in a day. So you are not going to give them the full amount of deficits. You are going to slowly give them over a few days. So a sodium of 165 is not going to be corrected to normal within one day. You are going to correct it over 3 days. And every day you check the sodium. As the sodium go down, you're going to keep recalculating and keep recorrecting because the fluid deficit goes down every day. So as your fluid deficit goes down, as your sodium goes down, the patient who is unconscious will definitely wake up. Confusion will improve. So when we're saying the patient is delirious, make sure you check your patient's sodium because it may just be because the sodium is too high. Okay.
Yeah, Alex, please, can I just come in with that one? So I know a lot of people actually say, as you rightly said, with 5% dextrose water, you still have to, total body water is just about water. There is no salt in it. But people will always say the best fluid you actually can use, if their gut is okay, you should be using NG and all the rest. But let's say because they're in hospital, we all prefer. People will always say, oh, you're giving 5%, their blood sugar will go up. 5% dextrose water, you're only giving 50 grams of glucose, which is not a lot. And you have the insulin with 0.45, you have 77 millimoles of sodium in that. So 5% actually doesn't. And don't forget, when you use 5% dextrose, it's not intravascular. It actually goes into plasma and you're going to pee it out. So the glucose is not going to stay in your body. It's only glucose that stays intravascularly. You've got the extravascular space, which contains your plasma. So you're going to pee it out. And people will say, yo, blood sugar, you go up, you can't use it. You can actually use it. Worst case scenario, you give them insulin. But you're going to pee out the glucose because it's not going to stay in your body. So the best bet is actually 5%, except if they are dry, then you can use 0.45. So that because that will still give you some of the 77% glucose, sodium that will stay intravascularly, then the rest will be extravascular, which you're going to pee out.
Okay. So D5 water to be used to correct it, or 0.45 if they're dry. Okay. Any questions, additions, subtractions? This is the GIM way. This is not. Okay, no questions. Okay, let's continue. So Mr. Infinity, 32-year-old truck driver, presented to the emergency department. He was driving his truck and suddenly noted that he was unable to release his fingers from the steering wheels. In the ER, his fist was clenched and toes involuntarily hyperextended. Patient was yelling in pain. So he had been smoking marijuana earlier on in the day and admitted to drinking 12 alcoholic beverages that day. So the patient had been given morphine, baclofen, IV fluids with no resolution. So the emergency physician did not, was confused and called you. So when you looked at the labs, the phosphate was 0.25, his potassium was 3.0, and his magnesium was 0.45. So patients had significant electrolyte abnormality with significant hypophosphatemia, which can cause the above symptoms. So you want to proceed to correct his phosphate. So how do we correct phosphate? So anything less than 0.75, I will correct either with IV or oral. So phosphate itself is important for cellular energy metabolism, and it results from the transcellular shifts, renal losses, GI losses, or inadequate intake. And if your sodium is depleted, you can have some neuromuscular and central nervous system issues. Clinical manifestations, they can have muscle weakness, respiratory failure, rhabdomyolysis, seizures, impaired oxygen offloading from the hemoglobin. So how do we treat sodium, phosphate? So you have, again, IV formulations, oral formulations. Oral formulations for phosphate, 500 milligram. They are usually effervescent tablets. Phosphate is a medication you don't want to give and go away. You don't want to say 500 milligrams daily forever. You want to give a stop date, because if they are phosphate overload, they can die from being phosphate overload, and they may need dialysis to take it off if they become significantly hyperphosphatemic. So usually I will go 500 milligrams twice a day for 2 days, then stop. Okay. depending on what the phosphate is. If the phosphate is less than 0.5, I will just give 1 dose and see what the result is the next day. With a patient who is significantly symptomatic like this patient, the potassium is also low. You can go ahead and give a combination of potassium and phosphate IV, which is potassium phosphate. You can give 15 or 30 millimoles. For this kind of patient who is symptomatic, I just go ahead and give the 30 millimoles. It runs over 4 hours. Wait at least an hour, then we check the electrolytes again. If their potassium was normal, you don't want to give them more potassium, so you can give them sodium phosphate, 15 or 30 millimoles. And if they're not symptomatic, you can use the tablets. Okay? So that's for phosphate. Again, don't prescribe your phosphate 500 milligrams once a day for them to go home with. Don't do it. Because I've seen a patient die from hyperphosphatemia before from a resident giving them phosphate ongoing. The phosphate, before you knew it, the phosphate was already 4.5. The patient died from it before they could get dialysis. So never do it. All right, so hypomagnesemia, what are the causes? Renal losses, RTAs, diuresis, hypokalemia. Always try to correct the magnesium so that your potassium will also correct. So patient can also have GI losses, malabsorption. Most patients who have had like weight loss surgery can malabsorb magnesium, so they need to be on magnesium. When you put in your NG to do your suction, you can drop their magnesium levels too. So from transcellular shifts, they can have low magnesium from refeeding syndrome, or they're recovering from hypothermia, okay? So patient can also be from decreased intake, malnutrition, alcoholism, which is the case of our patients, or when they have parenteral nutrition. How do you treat magnesium? You want to give them, 2 grams IV, or you can also give them magnesium oxide. While I don't use magnesium tablets in the hospital because, once you give them more than 2 doses, they can have diarrhea. So I just usually will give IV magnesium because most of my patients with magnesium deficiency will have issues with, arrhythmias, atrial fibrillation. So really, I always want to get their magnesium really up to the normal level. So I will go with 2 grams IV, and I'll wait at least 2-3 hours, check it again. If we are not within normal, I'll give more. So magnesium oxide, I usually use it for patients when they go home. If their magnesium is slightly below normal, I will tell them to take 420 milligrams once a day. Most of the time, some of these patients, for some reason or the other, if they have leg pain, they tell me that the magnesium works for their leg cramps. And some of them who have issues with constipations, I will give them, take it twice a day. It also helps them with their bowels. So that's for magnesium.
Dr. Akinfiresoye, I want to know how the maximum dose of magnesium sulfate you do in a day.
I usually give 2 is the maximum, 420 milligrams twice a day. Okay, like for
IV. Yes.
It doesn't really matter, actually. It depends on how much it takes you to bring the potassium up. I've never really given more than 8 grams in a day. But again, if you are resuscitating them, if they are pregnant and they are in preeclampsia, you're giving like 4 grams. So really, it just depends. There's really no maximum until you're able to get that potassium, magnesium to where it is.
Okay, thank you.
Yes, but oral, the maximum I always give in a day is 2 tablets because they will have diarrhea from it. So I don't give more than the 2 tablets.
And the reason why I'm asking is I just want to know the urgency, like how urgent is the correction of hypomagnesia, particularly for those who are not symptomatic, but maybe have hypokalemia, and you now pick magnesium deficiency. And
Yes.
let me say 0.4, like how urgent do you want to get it back to the normal range?
I will just give 2 grams. Because eventually, before you know it, they will start having like short runs of SVTs, or if there are people who have underlying atrial fibrillation, the atrial fibrillation will start to act up. So if you just pick it while they are in the hospital, just replace and do it with IV, because, you know, really the oral formulation, again, if you want to give enough, they will start having diarrhea. So as soon as I pick it, anytime I do blood work and the magnesium is low, I just will replace.
Sorry, please. The magnesium collection, do you give it as bolus or you give it over maybe 1 hour or 2?
You give it over, no, the nursing have their protocol. So I think the 2 grams, it usually goes over 1 hour. I think so. I don't really have, you don't have to write the time. They have their protocol, how to give it with their IV machine thing.
We have 2 hands, Dr. Salami and Dr. Awobem. And for others, we can also try to use our hands up sign.
Okay.
Also, we can write questions so that we can read it because of our time. Thank you.
Dr. Salami. Dr. Salami? Okay, Dr. Awobem.
Yeah, sorry, it's me again.
Can
I
you
know,
hear me?
again,
Oh,
like I said,
sorry.
disclaimer,
Okay,
I'm an
Howard.
ENT, so
No, it's okay. No, that's okay. You can ask any question that you're here to. You're here. There's no judgment.
yeah.
Ask as much.
So magnesium is kind of like a minefield these days. Everybody tout magnesium as one of the wonder medications. So, and then I've actually spoken one-on-one with a compounding pharmacist in the past, and the question is, which is the best magnesium? You have the oxalate, you have the citrate, you have the glycinate. I think there's one other one, and some are more prone to produce diarrhea more than others. Some tout the glycinate as your best for magnesium supplementation. Which is the best magnesium? There's a lot of them out there, and there's all kind of press as well.
I just stick to oxide. You know, you just stick to what you know. So I just stick to what I know. I just give them magnesium oxide. That's all.
Okay, thank you.
Yes, but but almost of these magnesiums are over the counter these days, and they will tell you which one is less this. But again, as I said, yeah, I just stick to one. It's hard to like have an idea of what everything does, so just stick to one.
So Dr. Akinfiresoye, this is Dr. Salami.
Yes.
So my question, I know this is an acute situation we're talking about, but we have patients who have chronic magnesium deficiency and who have severe GI loss. They've had multiple surgeries and they have very bad absorption of magnesium. In that situation, I have a patient that have been referred for high-end magnesium. What is the potency of this and how often can they get it? Because this patient has so much high magnesium and has so much lump on the bum. And at some point in time, I was like, we should stop this. But definitely she can't get the magnesium through oral form. She goes to the hospital, they correct it acutely, they discharge her home and say, go and continue with your high magnesium. So what will you advise in this situation? Thanks.
Well, funny enough, I've never really given magnesium IM, now that you say so. But for this kind of patient, if they're already having like, you know, skin manifestation and all these extra bumps, you can arrange for them to have the magnesium once a week. Actually, they do have these IV clinics out of town. It depends on where you are, and you can arrange for them to get the magnesium once a week IV. They are not going to absorb, as you said, because they've had bowel surgery, so the oral formulation will be useless for them. Yeah, but this person will likely need to have the IV ongoing outpatients.
Thank you.
Yes. Is there any other questions? Okay, so we have come to the end. So in summary of everything I have said, it is important to know that electrolytes and minerals in our body have like have an electrical charge, and they are found in the blood, urine, and body fluids. Okay, it's important to also it is very important to maintain the right balance of electrolytes in the body, and to ensure proper functioning of your body chemistry. So electrolytes maintain muscle action, specifically cardiac, heart, and neuromuscular processes. So if you follow this simple practical approach to ensure safe and effective patient management, you'll be successful in your electrolyte replacements. End of dictation. Any questions?
Thank you, Dr. Alex.
Dictation, sorry, end of what do you call it, presentation.
Thank you very much for your time today. I think we still have more questions, which we are going to give us more time. We have a few more minutes before we end this session today. But my own question is about chronic hypophosphatemia. Patient is stable, there's no potassium derangement. Do we need to correct? Because we do see this when we do some routine blood work, especially in long-term care, which some of us are involved. We see a lot of that derangement. How do we go about this?
Usually, if it's not less than 0.5, you may not have to correct if it's not less than 0.5. It's when they go less than 0.5 that they start to have these symptoms. So if they're in long-term care, they're above 0.5, you know, it most likely has to do with some kind of their kind of diet and stuff like that. If it's above that, you don't have to correct.
Thank you. Any other questions?
There's some things on the chat. I can't really read the chat, so I don't know.
I'm trying to read this. It's all about, yeah, amazing. Thank you. Everybody just trying to appreciate your presentation today.
Thank you for the
1 minute. Okay, go ahead.
Thank you for the nice presentation. Please, can you recap how we should correct for magnesium if it's low?
So for magnesium, just give
Right.
grams of IV magnesium, magnesium sulfate. Okay.
How many grams?
2 grams.
Okay.
And if you want to give oral, you can give magnesium oxide 420 milligrams twice a day maximum, because you want to prevent diarrhea if you go more than twice a day. Okay. And you know, as you replace, you can recheck again every 4 hours to see if it's adequate, then you can give more.
From Dr. Jami. Yeah, Dr. Jami is asking a question about herbs that can be used for calculation. Maybe Dr. Jami will be able to do that research for us. And I think we are going AI most time now. Less people try to come up with things. Maybe this is time for us to do more research or work on herbs to be doing all these calculations. We have MD Calc. We have a lot of apps you can download. Yeah, there are apps already.
Yeah, they are there on the apps. You can use the apps. But if you're somebody who's going to do your exam, if you're doing like a family medicine exam or internal medicine exam, you don't have the apps to use there. So you have to like know that calculation. And when I have my residents, I don't expect them to pull out their phone and start calculating with an app in front of me. So I want them to know the calculation. So just know it. It's not difficult. But if we're already practicing, yes, don't stress your brain, just use your app.
Thank you, Dr. Alex. Therefore, we have a lot of residents on the Zoom meeting today. Please try to do the calculations, and those of us that are still preparing for exams, let's try to memorize those formula.
Yes, yeah, because if your sodium is low and you have that calculation and you write it down on the patient's chart, I can imagine how impressed your staff will be. Oh my God, look at you. You know, it's an extra step that you're doing, that you're making. If I have a resident who already wrote that calculation and tells me, this is the fluid deficit, I will be so impressed that all the results, I'm just going to give them excellent exceeds. So this is something that you should know, you should take an extra step to know.
Dr. Alex, I have a patient at the long-term care who's on chronic water restriction by the family doctor. I do go to cover once in a while. Is this something practicable?
And that's why I don't like to go less than 2 liters, because if they're too dry, you know, patients are not comfortable when you restrict them too much. There's old people cannot drink more than 2 liters anyway. So 2 liters is fine to fluid restrict. Anything less than 2 liters, I think, is too much.
Because the scenario is all about this patient takes more alcohol instead, and it's confusing. You try to restrict fluid, patient is taking alcohol sometimes. How do we explain that? Do we even need to put this patient on restriction when patient is not symptomatic?
Yes, you don't have to restrict the patient if they're not symptomatic. It depends on why they're restricting the patients. Some doctors will restrict because of fluid overload. Some will restrict because of sodium. So it just depends on, you don't have to restrict them if they're not symptomatic. If they're on the nursing home too, why restrict them? This is the end of their life. So
thank you.
yeah.
For the slides, we're going to work on it, and I will ensure that we have it. Because most of our slides go onto the website. The IT people are busy because of the conference. That's why we've not posted the last session, but all this will come onto the website. I promise. Thank you.
So just text me your email, then I'll send it to you then that way.
Okay, thank you. I'll do that. Okay. I have it recorded already. I'm also going to download the video. We'll put it, and for the slide, I will get it from you. Thank you.
Okay. And you guys have me on WhatsApp, so you can text me on WhatsApp if you have any questions, any clarifications. I'll be happy to respond. Okay.
10:30 a.m. already. This is the end of the presentation today. Next month we'll be in the conference, and September will be off. And I hope we'll be back in October. Thank you, everybody. Have a wonderful weekend.
Thank you.
Thank you.
Thank you.